Hey everyone, this is Michelle again. We are going to partake in a little lecture here for our very last class together. You know how I like to have fun, so I thought I would just record this brief lecture on disorders of mental health disorders of children and adolescents so that we could use our last 1 hour together to play Who Wants to Be a Millionaire? So here we go. Many of you perhaps have children. Children are very precious. As parents, we worry about their health. When our children have issues and crises, these issues and crises affect us probably more than they do the kids. So this is typically something that will affect the whole family and be disruptive to the whole family and the family's ability to function. So what is the prevalence of mental health disease in children? 1 in 5 children or adolescents in the United States have a mental health illness. 1 in 5. 2/3 of all young people with mental health problems are not getting treatment. Oftentimes I think what I find is that parents think that it's just a phase that the child is going through and they'll eventually grow out of it. And so, you know, a lot of kids are not brought in for evaluation. Where was I? Suicide is the second leading cause of death among individuals age 15 to 24, and we did talk about this in our mood disorder lecture also. And it is the 6th leading cause of death for children aged 5 to 15. And what they have found is that for every teen or young adult who commits suicide, there are 100 to 200 more that will attempt suicide. Researchers are continuously refining information on brain development, trying to determine factors that can contribute to the malfunction of the developing brain during significant milestones in a child's life, and how these factors affect their mental, physical, and behavioral aspects of their life. Studies have found that gene disruption affects brain function. That makes sense, right? Early childhood stress and or trauma can alter actually the brain's stress response system, and over time those circuits actually can change permanently. And this will continue into adulthood then. They have also found there are several environmental factors that can trigger genes to mutate, kind of turns them on or off, and that affects the behavior they see across generations. So they can see a pattern of certain disorders in a family. And then finally, they're focusing on neural circuits in the brain and how these develop and how genes and the environment disrupt those. And we will talk a little bit about, when we get into each specific disorder, the things that they have found related to that specific disorder. Oh, I skipped did I skip something? Hold on. I think what I wanted to say was that there should be another, hold on a minute, you guys, I got mixed up here. All right, this should go up here. Okay, just one of those goofy little slips. Okay, so common childhood mental illness conditions are listed here for you. I wanted to just say that eating disorders we are not going to cover in today's lecture because that material was covered with you in second semester, I believe with Linda. Anxiety disorder, mood disorder, and schizophrenia we are not going to cover today either. And that is because, you know, we just covered those previously in the course. And really the treatment for children will actually, the nursing process and treatments for these problems, anxiety, mood, and schizophrenia, are no different than they are for adults, except when medications are being used, there are some general principles that we have to take into consideration with children. So specifically, there's a very high incident rate of medication errors related to dose with children. Just minor miscalculations, like having the decimal point in the wrong place, can have extensive consequences and toxicity concerns for children. Many of the medications do not come in pediatric formulations, and so healthcare providers actually order those meds in adult formulations and just dilute or order smaller doses, which can also lead to some errors. Many adult medications have not been tested or researched adequately for pediatric populations, and so they're essentially being ordered what they call off-label use. They're being used without any research or backing up to say that they're efficient or effective for children, or actually what kind of side effects they happen in children rather than adults. Malnutrition and dehydration can drastically exacerbate drug effects and lead to toxicity in children. Some cultural implications include herbals. If they're using herbals, they can interact with medications. And when you're preparing a medication for a pediatric population, we typically are preparing some kind of a liquid formation and maybe adding some flavoring. So what's important with that is when we reconstitute that medication powder, once it is mixed, there's very strict expiration dates for those mixtures. So you're going to have to make sure and be checking your labels from pharmacy. And then finally, we have some concerns with the adolescent population regarding medications, because there is a lot of misuse by this population for overdose suicide attempts, and also peer pressure and sharing for illicit drug use is also a problem. So what can you do regarding medication in children to try and help with these problems? Always remember that these children are minors, and before you start any kind of a medication, you need to have consent for treatment from the guardian or whoever is taking care of that child or has legal custody of that child. You also need to know what you're giving. Make sure that you've looked it up. Know exactly what dose is required for children and the potential side effects for children. Again, they may be adult doses, so you're going to go with the side effects that are listed for adults, even though you have a child. So you have to just be very hyper vigilant about watching that child after you've administered a medication for any signs of abnormal behavior. You also want to ensure that you have an accurate weight. Most pediatric doses are based on weight, and a report from the guardian regarding what the last known weight is not accurate. You want to make sure that you're getting the weight, you are getting the weight with the patient child present. Always double check your order. Ensure there are no interruptions while you're preparing the medication. Again, even a minute error in the dose can have drastic effects. And then always, always, always have another RN double check when you're dealing with pediatric doses. Double check your preparation and the order so that you just have another pair of eyes on that. So those are just some considerations that are a little bit different than adults when you're dealing with the anxiety, mood, and schizophrenia. Otherwise, the nursing process, your assessment, your plan, and other treatments are going to be the same as what we talked about for adults. So anxiety disorder, there is one aspect that is a little bit different than than the adult anxiety that we spoke of, and that is the separation anxiety. Typically, adults do not have separation anxiety from another adult. However, children do experience this, and basically it's anxiety caused from being separated from their parents or their home. So they can have excessive anxiety anticipating, say, going off to school. They can obsess about being lost or kidnapped, have trouble sleeping because they're worrying all the time, and refusal to attend school, or any kind of vague physical symptoms like tummy aches and stuff can be an indication that this child is suffering from some separation anxiety. Again, treatment modalities are going to be the same as they were for an adult. You're going to be using antidepressants, antioxidants, and potentially, well, not really. We'll leave it at that. Usually those are the two main drugs that they use. As far as mood disorders such as depression, something unique with children is that most of the time it can be related to abuse or neglect, homelessness, maybe some marital issues, a divorce, things like that, learning disabilities, negative responses from peers can also contribute to depression with children. So the complications are similar to what we see in adults. Adults who have depression maybe have some financial difficulties. They are unmotivated, don't go to work, can't keep a job, that kind of thing. Children, it's the same thing except they're in a different setting. So what you're going to see is school failures, maybe some drug and alcohol abuse to try and self-medicate, maybe some sexually promiscuous behaviors, running away from home, just trying to escape it all, maybe some illegal behaviors, and then again, suicide is a very, very big concern with this population. So relevance of the family history, and I think we kind of already alluded to this, but typically, genetic connection is there, and you will see disorders carrying on through the generations, especially depression, anxiety, alcohol dependence, and conduct disorder. And parents with ineffective coping strategies will, this is what we call nature versus nurture, right? There's the genetic component, but then there's also the environmental component where children are actually, the parents are modeling bad behavior, and children are learning how to respond to situations based on what they see with their parents. So they get this learned helplessness or anxiety because that's the kind of reaction to stress that they are seeing or what's being modeled for them. Inability to learn how to master their environment. An emotionally unavailable parent places the child at risk to be unable to make those emotional attachments either. Abused and neglected children are also at risk for emotional, intellectual, and social handicaps. Identification with the aggressor and can stop these things from producing, and then usually there's some cognitive behavioral therapy that is done with the child to try and unlearn these dysfunctional behaviors that they have picked up from their parents. So what does a healthy child look like? These are all the aspects that we would hope our children would exhibit if they are mentally healthy, and we've done a good job as parents to bring them up. So you could gather opposite of these traits would be characteristics of a mentally ill youth. Okay, so we are going to talk about the autistic spectrum disorder. It used to be called pervasive developmental disorders, but the new DSM-5, what they did is they took Asperger's out of there. You might have heard of Asperger's, which was a milder form of autism where the individual is able to function pretty well. And they lumped all of these autistic disorders together under one big umbrella, which they call the autistic spectrum disorders, okay? So what we will be talking about today is autism, Rett's, and childhood disintegrative disorder. So autism, basically this is diagnosed by the time that the child is 2 years of age. There are specific behaviors that are associated with this disorder, which we will go over in a little bit. But what they have found the cause is that it's an abnormal functioning of the left side of the brain, which controls language, logic, and reasoning. So even though you have deficiencies in communication, both verbal and nonverbal, they have social interaction problems and repetitive behaviors. Many of autistic children will actually have exceptional skills in certain areas, such as art or music or math. And actually only 40% of autistic children are intellectually disabled or mentally retarded. Okay, so the 3 symptoms you see on the screen are the 3 key symptoms that they're looking for to diagnose a child with autism. So I already mentioned the abnormal dysfunction of the left brain. They also feel that there is a genetic component to autism and possibly some environmental factors, and what they're considering is perhaps parental age at conception, if there were any maternal infections and exposure to toxins during pregnancy, any complications during the pregnancy and or with the birth. They've also linked lack of folic acid during pregnancy to autism and prematurity of the infant. There was a lot of debate at one time regarding vaccinations and perhaps a link with autism. Children receive multiple doses of medications prior to age 2, and the older formulations of vaccinations had what they call thimerosal in it, which was a mercury-containing preservative. So many associated the vaccines with the incidence of autism. However, there have been multiple studies conducted to evaluate this association, and it is unsubstantiated, or it has been unsubstantiated. Even though the studies show no link, vaccine companies did stop using thimerosal. So the current vaccinations do not have that in it. So unfortunately, what happened from that whole situation is that it started a movement with parents to refuse vaccinations. And that continues through today because the layperson is not educated on the fact that there is no link and are still going on the presumption that vaccinations cause autism. So even to this day, you have parents that are waiving or declining vaccinations for their children. And we've started to see the effect of this with non-immunized children having a resurgence of pertussis and other vaccine preventable diseases. We've had a horrible, horrible time getting a handle on pertussis, and part of it is believed to be waning vaccination in immunized people, and the fact that the resurgence was caused by unimmunized children getting the disease and passing it on. So the presenting symptoms of autism include severe communication difficulties. You'll have children that look withdrawn. They have delays in language. They may seem immature. Inability to name objects. They use repetitive language, oftentimes making high-pitched kind of squealing sounds. They speak in single words, or they will repeat phrases over and over and over again. Kind of a babbling, kind of a sing-song speech. They lack the ability to do spontaneous make-believe, and they cannot imitate people, okay? Social interactions, things you're going to see with dysfunction in this area is a lack of responsiveness or interest in other people. They tend to not make eye contact or facial what am I looking for the word? Sometimes I have trouble with words. They don't make facial gestures, or they don't make faces. They can't make a happy face or a sad face or a mad face. They don't get those emotions, okay? They have an aversion to any physical contact. They don't like to share. They can't play back and forth with other children. They don't have that cooperative ability. And essentially then they do not have any social friendships either. The repetitive behaviors can be very rigid. They can be very rigid. They have to adhere to a routine, and if they don't follow the routine, it has catastrophic effects on them, and they will have a tantrum or just completely be unable to cope with that. They can be preoccupied with certain sights, sounds, smells, textures. They obsess on things, okay? So from the nursing process perspective, basically for assessment, you're going to want to, when they come in for well-child visits, that you're going to be wanting to use the developmental scale of what's appropriate behavior at each developmental level, and check the child to see that they are able to do those developmental milestones. You're also going to want to assess relationship between the parent and the child, just to see if there's any dysfunction there, or if the parent can perhaps give you some indication of abnormal behaviors the child might exhibit at home. And then you want to be looking for, is there any indication that there's possibly abuse going on. You can see the nursing diagnoses there. Interventions. Oh, hold on. I'm sorry if I seem a little disorganized. I got to go back. I wanted to show you this little video here. You know how I told you guys, my philosophy of teaching, I really believe that you need to use all your senses to try and understand things. So I have a video of autism because I want you guys to see what it looks like, because words are only so good, but if you can see it, it's so much better. So let's go ahead and watch this. It's like a 2-minute video.
Okay, here's the plan. You're gonna want to turn right
in 0.2 miles.
Here. Watch the lane.
Backseat drivers just met their match. Introducing the entirely new Sonata.
You forgot to turn off the...
From Hyundai.
Hi, Joey.
Hi. It's party.
Louis. I'm Louis.
He's Wayne. Hi, Louis.
If you could take the autism away, would you do it?
Yes. I always pray for that miracle. And one day I was in church and my daughter says, Mom, do you know that God made him that way? So then I'm like, God made him that way to make me learn a lesson, probably. Hi, Kate. Say hi.
Carol's daughter,
hi.
Kate, is
school?
not autistic.
Hi, Kate.
You don't want to say hi? You're being shy?
That's okay.
I'm just going to bring her in. In. Down. I might call my husband in. Would you mind? Tadeo! Hold his legs. Breathe. Go get some water, Tadeo.
Shall I get some water?
Thanks.
Would you like us to step out?
No, unless I let you film, and nobody's going to ever know that this is true autism. That's it. And no, but a lot of parents don't want you to see that. Breathe through your nose, Joseph. You sorry?
Sorry, yes.
Okay. Can I have a kiss?
Everything's okay now.
Everything's okay now. Oh.
Oh, we're really sad to you.
Yeah, everything's okay.
So how very interesting, isn't it, actually, to be able to visualize what an autistic child looks like and what the parents have to go through. Did you notice the little girl in the room all curled up in her chair, almost scared of the whole situation? She has to live with that every day, and those parents have to live with that every day. It's very exhausting and taxing for the parents also. And actually, the one technique that you saw in the video is one of the interventions that are used, and it's called therapeutic holding. So they kind of smothered the child, not forcefully or meanly, but they smothered the child with their body to try and help the child get back under control. And then they were having him deep breathe, and they were holding him. The mom put down some pillows so that he couldn't hurt himself while he was having this temper tantrum. And they were able to, through that therapeutic holding, to pull the child out of that temper tantrum. But I thought it was a very, very good example. So therapeutic alliance, again, you want to build a relationship with the patient if you can, and with the parents, and work together to try and teach them coping mechanisms and ways to overcome or control the situation. There's professional family therapy and group therapy also. Again, the family is disrupted by this behavior, and if abuse is ruled out, you can build an alliance with the guardian to teach them ways to cope and handle behaviors appropriately. And the little girl, she needs to be in that family therapy also, because every single family member is affected by this behavior. For adolescents, it may be important to assess relationships with peers. That would be a key area for that population. Oftentimes in group therapy, they will try some interventions such as play with the very young children. They may do some play and talk with grade schoolers, and then just talking about peers and specific problem solutions for the adolescent population. Typically, autistic children, they are involved in a multidisciplinary team. You have your primary care physician handling general medical issues. You have psychologists dealing with any psychological needs if there's any underlying conditions. You have your neurologists who are dealing with the brain chemistry. And then these kids have delays, so they're going to be in speech, OT, and PT to try and regain some of that developmental functions that they've lost. Oftentimes they'll try cognitive behavioral therapy. What they'll do is they'll try some positive reward system for the behaviors. Example is like points and levels, where the child receives points for good behavior and is rewarded with privileges based on the points. And you know, with a child severely autistic like the one we just saw, you know, a points and levels system may not work very well. You would just need to get down to the nitty-gritty, and you can praise them for good behavior and then restrain them or whatever you need to do to handle poor behavior. Play therapy is often used with children. It's a good way to explore how the child is feeling, and the activities, you know, are in a safe environment to help build a relationship with that child. There's hardly ever anything bad happens as I don't know where I'm going with that. So play also is imagination and reality, but it exposes some of those internal feelings that the child may be struggling with or issues. We often sometimes will have children draw pictures to try and depict perhaps what's going on in their mind. Draw me a picture of your family, and sometimes you're very surprised at what comes out in that picture that you would not anticipate coming out. You know, children can draw some very graphic pictures. And for some reason they find drawing pictures so whatever I'm trying to say is that sometimes children are told, if it's a dysfunctional, abusive kind of situation, sometimes children are told not to tell anybody. But typically, you know, they're not told, don't draw anything for anybody. So you may get information coming out in a picture that otherwise wouldn't come out verbally. So I hope I made that clear after I bumbled and rambled about that. So always follow the child's lead. Be warm and friendly to build that relationship. Let the child express feelings. Recognize those feelings and reflect them back to the child to gain insight into, you know, further feelings. Accept the child's ability to solve some problems, personal problems, but, you know, set limits to provide reality and security for the child. You may want to use hand puppets sometimes and do puppet shows or dramas where the child can act out situations. All of those things work. I mean, you just have to be a little creative with children, and not things that we would do with adults, right? Pharmacology is geared towards basically symptom management. Okay, so if we found an underlying psychological problem, we're going to be treating that. We're going to be treating symptoms the child may be exhibiting. There really is no cure per se for autism. So you might see stimulants being used to decrease the child's outbursts. I mean, you can maybe see antidepressants being used if the child is overly withdrawn, so on and so forth. So these two orders, Rhett's disorder and disintegrative disorder, childhood disintegrative disorder, excuse me, are both regressive disorders, okay? So they have the same behaviors and symptoms of autism. However, these children will develop normally for a period of time and then regress, okay? So Rhett's syndrome or disorder is observed only in girls. Onset is typically by age 2. They develop normally, hit all of their normal milestones months 6 through 18, and then they regress into autistic type behavior and loss of functioning after that. Childhood disintegrative disorder, on the other hand, affects boys more than it does girls. And the onset of the regression is later, between years 3 and 4. Etiology of these conditions is unknown. They believe that it may be a mutation of a single gene series. Characteristics, again, are similar to the autistic characteristics. And the only one that is different with childhood disintegrative disorder, the child will have such severe digression that they actually will lose bowel and bladder control. So the next disorder we're going to cover is attention deficit hyperactivity. I'm pretty sure most of you are well aware of this condition. It has been around for a while. It's gotten a lot of media related to, are we over-diagnosing our children with ADHD, and are too many kids on medication because of it? So I'm not going to go that route. I'm just going to try and talk a little bit about ADHD. There are 3 subtypes. One that is primarily hyperactive, one that is primarily inattentivity, and then the third is if they're mixed. The symptoms you can see listed there. The symptoms have to have been going on for 6 months or longer for a child to be diagnosed with ADD or ADHD. The average age of diagnosis is 7 years, and that seems to be because the child is now in the educational system, reaching the levels, the grade levels, like first, second, in which it's not all about play. They actually have to start following social rules, sitting quietly doing homework, working independently, things like that, that the teacher picks up on now that this child doesn't fit the mold with all the other children, and there may be a concern. So typically the school system and the teachers are identifying attention deficit disorder problems. The etiology is really unknown. Again, they feel that there is some genetic component to this disorder. And then again, they also think that there are some environmental issues that contribute to ADHD. And some of those are smoking and alcohol use by the mother during pregnancy. There's some data that indicates perhaps lead exposure either through paint chips or lead piping in the household contaminating the water could possibly be a link. Also, they're looking at food additives such as food coloring and preservatives as being a component to the problem. So inattentiveness, basically the child is easily distracted by irrelevant sights and sounds. They have a failure to pay attention to detail. They're very careless. They can't follow directions. They are always losing or forgetting things. And they seem to be easily bored. But they are able to play video games and Lego. So I've always found that quite interesting, that I don't know why video games can keep their attention but other things can't. They're very impulsive. They often interrupt conversations. They blurt out answers without hearing the whole question. They have difficulty waiting in line, waiting their turn. And then the hyperactivity, obviously, you're going to see some nonstop talking. They're jittery, they're fidgeting, they run, climb, you name it. These kids just cannot sit still. They have a very low tolerance for frustration and often have temper tantrum or outbursts also. So how does this, or how does the nursing process come into this? Assessment-wise, you're going to want to be looking at, what kind of relationship the child has with the caregiver. If the caregiver understands that the child is um, exhibiting these maladaptive or behavioral issues, and that they're problematic. Assessing cognitive, psychological lags or deficits the child may be having. Observing for any physical things you note, attention span, talkativity, ability to follow directions, and ability to control their impulses. All of these are things that you're going to be looking for, asking questions, observing. Nursing diagnoses are listed there. Interventions, basically behavioral modifications such as the immediate positive feedback and redirection of negative behavior or ignoring of negative behavior. Timeout. Quiet rooms are used when children get out of hand. Another technique is to divide large tasks into small pieces so that it isn't so overwhelming for these children. Maintaining routine schedules, trying to initiate an organization system. Again, therapeutic holding that we observed before can also be used for children with ADHD to reduce the distress, get them to relax and get back in self-control. Most of these kids are in special education programs. If there is some underlying mental health disorder, they will probably have some psychotherapy, cognitive behavioral treatment. And I also thought, ADHD is associated with oppositional defiant disorder and conduct disorders also. So you may be seeing some psychotherapy being performed and possibly the child getting some medications related to that. Family therapy is going to be very important. Again, these children and siblings, family members are all affected by these behaviors. So pharmacologic agents that we're using with ADHD are, the number one is stimulants. Actually, stimulants have an opposite effect on children than they do on adults. It gives them it has a calming effect on them and improves their the long-term effects of this disorder on children. This again, because it has an opposite effect on children than it does on adults, you may see or run into situations in which parents are stealing the medication from the child for illicit use, or adolescents giving away their medication for illicit use. So we have to be very careful with those kinds of things. So some common stimulants that are used are Ritalin, Adderall, and Concerta are three that come to mind for me. They're a CNS stimulant. They're usually short-acting. They may have some effect on norepinephrine and dopamine and serotonin. Okay. And predominant side effects that you would be concerned about with stimulants, children can develop tics. They typically will complain of a decreased appetite or upset stomach. They may be irritable, and we want to be very, very careful that we're screening these children's history for any pre-existing cardiac issues, because stimulants have been shown to cause stroke and MI in children that have predisposing cardiac issues. Also, stimulants have been found to cause suicidal thoughts in children and suicidal ideation. These increase. So again, we want to be very concerned with how we're monitoring children after we start this medication. So depending on the symptoms the child is exhibiting and if there are any underlying mental health conditions, you may see children with this diagnosis on antidepressants or adrenergic agonists, okay? A couple of examples of adrenergic agonists would be Tenix, which is, I have trouble with pronunciations, guanfacine, and clonidine. Both of these medications will decrease the activity of adrenaline in the child. Okay. Oppositional defiant disorder, you can see the list here. I mean, all children have some opposition or defiant times, and oftentimes they become defiant or oppositional if they're tired or they're hungry or upset, especially 2-year-olds, right? But ODD is defined when these episodes are more frequent or more severe than other children of their same age range. Oppositional defiant disorder, the etiology is unknown. However, it is thought to be related to the neural pathways, some dysfunction there, and some psychosocial factors also. They've actually made a correlation of low socioeconomic status and increased rate of oppositional defiant disorder. It can also be related to other mental health conditions as an underlying problem, such as the ADHD, any learning disabilities, mood disorder, or anxiety disorders. The characteristics are loss of temper, arguing with adults, actively defying, refusing to comply, deliberately trying to annoy people, and blaming others for their mistakes. They become very angry and resentful, they're spiteful and revengeful. And they don't care about losing privileges as long as they win the battle. Oftentimes, this is a precursor to conduct disorder, which we are going to talk about in a few minutes. So the nursing process with this disorder, basically you're assessing for power struggles, you're assessing for defiant behaviors, and you're assessing how this affects the child's life. A couple of nursing diagnoses there for you. Typical interventions that you're going to get is some outpatient treatment, again focusing on group therapy, family therapy, and individual cognitive behavioral therapy. Parents, you're going to be focusing on parenting issues and providing training to the parents on how to appropriately deal with the child's behaviors. The child will be getting some anger management classes. Parents and nurses will be trying to enforce the positive behavior, and kind of just like we did with the ADHD, they're redirect or ignore negative behaviors. Timeout and quiet rooms are used in therapeutic. Touch or hugging, restraining is also used. Pharmacologic interventions, again, are going to be based on if there's any underlying medical health condition that is diagnosed that we would treat, and symptom management. So you could see potentially these children on antipsychotics, stimulants, antidepressants, mood stabilizers, and the adrenergic agonists that we talked about already. Conduct disorder, this is a more, is that correct grammar, more severe? It is a very severe disorder in which the child is actually violating rights of others. They are harming other people, harming other people's possessions, things of that nature. Typically, this will occur before the age of 10. The child will be diagnosed with this. It affects boys more than it does girls. And the behaviors are persistent and more severe and violate social norms, typically. Children who have this disorder are very physically aggressive. They lack relationships. And then when they typically lack a self-esteem, and typically when they are called on their behaviors, they show no remorse. They have no guilt and they show no remorse. At least half of these cases of children who are diagnosed with conduct behavior will go on to have adult antisocial problems or be involved in the legal system as adults. Bullying is probably the first indication, or the first observed behavior that might give you an indication that the child has a conduct disorder. The etiology is unknown. Again, they think there is a genetic component, possibly dysfunction or injury to the brain and those neurotransmitters and neurosystems. Especially in the parts of the brain that affect emotions and impulses. They also do feel that there are some environmental components that contribute, especially dysfunctional family units with trauma and abuse being part of it. Again, it can be associated with other mental health disorders, ADHD, anxiety, mood, and learning disabilities. So here is just a rundown on the nursing process, things that you're going to be looking at. I think this is a pretty obvious disorder. I think in the assessment, the behaviors are going to be pretty obvious to you when you do your assessment or when you meet with the parent and the child. Interventions, again, are going to be around psychotherapy, anger management, depending on how severe the child could need to be hospitalized if they are so aggressive, and especially if they turn any of that aggression in themselves and try and do self-harm. Parents may not be able to handle children with conduct disorders, and the child may be placed in foster homes or group homes. Pharmacological treatments that you may see, again, symptom-related or underlying medical mental health condition diagnoses. So you may see antidepressants, anti-anxieties, antipsychotics, mood stabilizers, and the adrenergic agonists again. Techniques for managing disruptive behavior, and this can be utilized in any of the behavioral things that we've talked to, from autism to the conduct disorder. Redirection is often used. Sometimes you can try and use humor, but there are situations where obviously humor is not going to make any difference. Self-control of your responses to the patient, and teaching the patient and family self-control techniques. Providing early help, clarifying emotions, feelings, situations that may be contributing to the situation, changing activities, distraction kind of activities, removing the children from the situation, setting limits, and last resort would be to use restraints. Oops, what did I do? Sorry. This would sum up the lecture for today. Hopefully when we play our Who Wants to Be a Millionaire game, it will be some reinforcement of what we covered in this lecture period. So if you have any questions, jot them down. Things are not clear, make sure and ask me during class prior to us starting the game. So thank you for your attention.